Welcome to the discussion on postoperative care. Postoperative monitoring or postoperative care actually begins at the end of the operation, and then it continues into the recovery room, or what they call the PACU, and it continues throughout the hospitalization and the outpatient period. Your critical immediate concerns are obviously your airway. The next thing for the patient is pain control. We want to talk about their mental status and their wound healing. The other concerns we get worried about are urinary retention, constipation, DVT. We watch their blood pressure. If there are patients with diabetes or anything like that, we have to monitor their glucose. Their airway, most patients get extubated. It means that they pull all the breathing equipment out before you leave the operating room, and they have to be able to clear the secretions before they leave the PACU and go to either outpatient recovery, where they're going to plan on going home, or going out to a floor. And they absolutely will not let them leave the recovery room until they can clear and protect their airway. I want to talk a little bit about atelectasis. It's actually one of the terms I've noticed students don't pick up when they read, and it's super important that you know what it is. So the title of this slide, Prevention of Atelectasis and Hypostatic Pneumonia. So atelectasis is a complete or partial collapse of the entire lung or an area of the lung. And it occurs when those tiny little air sacs, the alveoli, within the lung are either deflated or they possibly fill with alveolar fluid. And now atelectasis is probably the most common breathing complication after surgery. It can be a complication of other respiratory problems like cystic fibrosis or chest injuries. And people can develop atelectasis if they breathe in a foreign object. But what we have to do is we have to be able to assess this, and we have to try to prevent it. So we have to auscultate the lungs. When I go in to assess someone and they've had surgery, I automatically listen to the lungs. There's no putting me off. And those of you that have had me in clinical, I go in there and listen to those lungs. And students will go, well, he doesn't want to right now. And I've been so trained to go in there and listen to bowel sounds and lung sounds right after surgery because they're so important. So you have to auscultate the lungs and assess the rate and depth of breathing. And what we have to do, we have to encourage deep breathing and coughing every 2 hours unless it's contraindicated. It's very rarely contraindicated. You have to show the patient how to do this. Normally I have them take like a pillow and hold it. And if it's an abdominal, it's really difficult for patients if they have an abdominal wound. I have to have them put like a pillow or a pad there and kind of pull in. And when they take a deep breath, it hurts. So they have to really work to take a deep breath and then cough and deep breathe. And if they can't cough, they can kind of huff cough. And you can take a look at your book on what that is. But basically that's you get in the ear, you try to make yourself cough to try to clear those secretions. And it's not unusual to have a little bit of cough after somebody's been intubated and they come up to the floor. Remember, they put a tube down your throat. It's really difficult on smokers. They have a hard time getting moving. And remember, people are in pain. They have an incision. We do want to medicate them so we can know that they can go and be comfortable trying to do this coughing and deep breathing. One of the most common things that you can give to a patient after surgery to keep their lungs open and to keep their alveoli open is an Incentivespirometer. And we normally have that patient do the Incentivespirometer 10 times an hour, every hour for the first 24 hours after surgery, and then they can do it every 2 hours afterwards. The thing I want to say is older patients need a little bit of coaching to figure this out. People that have been in a lot of pain, I sometimes go in and help them. Like when a commercial comes on the TV, I'll go, oh, it's a commercial. It's time to do your Incentivespirometer. And I will do it with them if that's what it takes to get them to participate and use the spirometer. Here is a picture showing how to use the Incentivespirometer. For those of you who are unfamiliar, most of them are a variety that look like this. They have the mouthpiece, they have a goal marker, and that means we want them to keep trying to work, the patient to try to keep working on expanding their lung. So as they take a deep breath, this little blue piston will go up, and you try to get them to hold the deep breath. And you say, well, I get a lot of students who think that you blow on this, or patients are trying to blow. It won't really work. It's to expand the alveoli. Take a deep breath right now while you're listening to me carry on here, and you take that deep breath and you expanded your alveoli area, and that's what we need them to do. If you look in this picture, this gentleman is holding his abdomen. He could possibly have an abdominal incision. That's what we have to get people to do, either to hold on to that area and pull it in, or put a pillow or a blanket there to give them some support while they try to deep breathe. One post-op complication that we need to discuss is deep vein thrombosis, or DVT. A deep vein thrombosis is a clotting of blood in a deep vein of an extremity, and it's usually your calf or your thigh. It can be in the pelvis. It does occasionally happen out in the arm. DVT is the primary cause of something called pulmonary embolism. If you think about that, there's a highway. Wherever this clot is in this picture down here, if it breaks loose, it goes directly up to the lung. DVTs tend to result from conditions that impair your venous return. It may be asymptomatic when you have a DVT, or you can have pain and swelling in the extremity. One thing that you do, we used to teach students about something called the Holman sign, where if you pull the foot back up like you're going off and on the brake, people would have calf pain. That isn't necessarily also anymore that diagnostic, but you may be asked somebody if they have a positive Holman sign. I will tell you, when I've seen a DVT, the leg is usually cool. You cannot get a good pedal pulse. You'll see swelling that's very obviously with a reddened area down in the leg, and it very not that difficult to recognize. If that DVT breaks loose and you have pulmonary embolism, your patient, you will know it. It's an immediate complication. It needs addressed immediately. The patient is extremely short of breath. And of course, in this picture, if you look in here, we want to prevent DVT. And the best thing that has come out in the last, I'm going to say 30 years to prevent DVT is what's called a sequential compression device. And basically, those of you who haven't seen these, they wrap these around the leg, they hook to the machine that's over on the table, and they will blow up with a little balloon that's in the back of the calf, and they will push the blood that's sitting back there and push it back into the circulatory system. You put these SCDs on as soon as the patient returns from PACU and anytime they go to bed. We do some other things that we give to patients to try to prevent a DVT. One is to administer low molecular weight heparin. That's a drug called Lovenox, administered sub-Q. The other thing that I just want to remind you is, say, well, what is the very best way to prevent a DVT? Early ambulation. We go in, and really quickly now, we get people up into the chair and get them moving around. And I will tell you, when they have had a major surgery, they look at you like you've lost your mind. Hi, my name's Cindy. I'm going to be getting you up to the chair. And they look at me like I just had surgery. And listen to me. This is a use it or lose it. I need you to sit up. We will medicate you. We will get you comfortable. And we will make sure that we do this to the best of your ability. But it's very important for you that you sit up in the chair. And sometimes people just aren't real thrilled when you tell them that, but we absolutely have to prevent DVT. When they're in bed, we have to leave these sequential devices on the legs. I want to talk just briefly about fluid balance and elimination. Normal urine output is 30 mLs an hour. If you know my little joke, my Sanka thing, stuff all nurses know about, if you decide to marry some gorgeous guy and you decide to move to Alaska to live with him and start a new life there, and you go into work at the local hospital, it's 30 mLs an hour. And this doesn't change. We want a patient to avoid within, this says 4 to 8. They will give them up to 8 hours. If they're unable to avoid, we need to do some nursing interventions, like get them up, run some water for them. If they're unable to go, and they have a little machine now that you can go and put on the bladder and see if there's enough urine in there. If they have urine and it's not coming out, we are going to have to put a straight cath in and empty their bladder for them. You have to notify the surgeon if the urine output drops below 60 mLs over a 2-hour period. And sometimes we start out in nursing school, they put you in a low-key environment, sometimes at a nursing home, and you don't see a lot of strict INOs. And when I tell students, you need to do INO on a patient, they look at me like, what? Well, listen to me. If someone had surgery and they lost fluids in surgery, you need to have hourly INO done on the patient. This is just a standard of care that everyone has to this is one standard of care that you have to do when you take care of a post-operative patient. Just a brief discussion on nausea and vomiting. We try at first we want to prevent aspiration. I try to do a lot of non-pharmacological interventions, a cool cloth, mouth care, no odors. We usually can give some ice chips. If the nausea and vomiting gets bad enough, there's usually a medication ordered that you can give, IV push or IM, to help a patient deal with the nausea and vomiting. One topic that we do need to discuss when we talk about post-operative patients is listening to bowel sounds and something called paralytic alias, and that is a new vocabulary word to a lot of students. A paralytic alias is a temporary stoppage of your intestinal peristalsis. It occurs most commonly after abdominal surgeries, particularly if they have to move the intestines around during the surgery. Symptoms from the patient: nausea, vomiting. They get a vague abdominal discomfort. They'll start to get very, very distended. When you go to listen to bowel sounds, you won't hear any bowel sounds. You'll hear no bowel sounds at all. A lot of times they start vomiting, sometimes large amounts. I've actually had somebody one time vomit. They vomited 3,000 mLs of a green bile, and the reason I know that is I now know that the wash basins hold 3,000 mLs of fluid because this poor guy filled that wash basin and I had to measure it. But that's what you have to do. And if they vomit that much and there's a risk of their potassium dropping and their electrolyte imbalance starting, then we're going to have to put an NG down. So that kind of brings your fundamentals into this topic. The best way to prevent a paralytic alias is to get people up and get them walking, get them moving. And that's the best way. But like I said, remember, this is a person who's just had major surgery, and sometimes getting them motivated to get them up and get them moving is very, very difficult. One of the things that we do when we assess a postoperative patient, if they're going to be staying at the hospital, we go in and we listen to bowel sounds and we ask them if they have flatus. I will tell you, you probably will have to ask them if they have gas. A lot of people do not know what flatus means. You need a good assessment of the bowel sounds. Once we hear bowel sounds, a surgeon will allow a patient who's had a major abdominal surgery to start on clear liquids followed by full liquids. Usually it says nursing may, advanced diet is tolerated. So that's something that you need to keep in mind, because patients ask you right away, they're dry and their mouth is dry, but they cannot eat until they get those bowel sounds and get that all clear from their doctor. I want to talk about medicating people for pain. You should be familiar with a PCA at this point. It's a patient-controlled anesthesia pump. I talk a little bit about that in pharmacology. If the patient has a PCA, he is able to hit the button at a predetermined interval to give himself pain medication, but that machine is not without you doing some assessment of the patient's pain level. He needs to understand how to hit it, what a pain scale is, then his family needs to know they don't need to hit it. The patient needs to have a good respiratory status and be alert and oriented enough to receive medication through a PCA pump. If you're not using a PCA pump, one of the newest things that you see is called a nerve block. And what a nerve block is to try to avoid some of the problems people have with pain pills, is they basically put a nerve block in the area where you have had the surgery, and you feel pretty good after the nerve block. People don't seem to need a lot of pain medication when they do a nerve block. It's becoming very, very common treatment for patients. If they don't have a PCA or a nerve block, and you are giving medications, either PO or IM, you should give them consistently for the first 24 to 48 hours post-operatively. Sometimes you have to remind patients to request the pain medicine before the pain becomes severe. And I have a hard time with this sometimes, with students giving me wrong answers and they're arguing with me about test questions. The thing that they argue with me about pain control is I cannot ask a patient who has major surgery to cough and deep breathe and get up and move around if I don't medicate him. And the student usually tells me, well, doesn't the medicine cause respiratory depression? Well, yes, but I'm not going to medicate him that much to cough. You have to kind of go and you have to do a good assessment. I do not want to depress respirations and the cough reflex. I just want to take the edge off the pain. I cannot make their pain level 0. I'm looking to assess it. If I go into the room and they tell me it's a 10, my pain is a 10, I don't think I can cough and deep breathe or get up. I said, let's try some pain medicine. I give them some pain medication. We make a plan to get up at a predetermined time, about 30 minutes after I give it. And I want to see that pain came down. If it came down under 5, I consider that, is that going to be effective for you? We're going to get you up. And if it's not, then we're going to have to readjust that pain medication. It is something that you have to kind of work with the patient with. And you have to assess that pain level, I would say at least every 3 hours. If you do have the opioids and you give it, those of you, the students that I'm addressing this presentation to are in pharm or have had pharm, as you know, the opioids will depress your respirations. They do cause constipation, which we already have an issue in postoperative patients. You can get nausea and vomiting from the medications, but we still have to use the pain medications and work with the patient to try to get the fewest side effects and get this person up and get them moving. Please don't forget about your non-pharmacological measures. Get people to get plenty of rest. Have them turn, cough, and deep breathe. Reposition them if necessary. Make sure that their bladder isn't distended and full of urine, and that can cause discomfort. Make sure they're warm enough. They're always cold when they come from surgery. It's very, very cold in the OR, so they have a cold in the OR, so they don't have bacteria grow. I've used distraction and imagery. Teach relaxation techniques. Make sure they're warm immediately after surgery. Make sure when you are doing your reading and your learning during the week that you understand the term primary intention. There's also a term in your book called secondary intention. And the only way I don't have myself visually up on the screen here, but primary intention example would be a lady who has a C-section. They cut her open and they stitch her back together, and both sides of the wound are even, and they heal up down the nice wound, and the wound heals up. That's primary intention. Secondary intention is when somebody has a drain in, or they have some sort of infection that's been cleaned out, and you should take a look at that and have a general idea of what those are. But you got to remember about healing in a wound. We want people to rest. We want to decrease their metabolic rate. We want all their nutrients to go to their healing. Some of the nutrients that you want to think about: protein. Vitamin C is absolutely necessary for collagen production. Your minerals, zinc, copper, iron, all assist in the formation of collagen and help a wound to heal. Also, please remember it is your job to report and document any evidence of bleeding, purulent drainage, anything that's serous sanguinous, anything that looks unusual on a wound. Two wound care definitions that you need to commit to memory are dehiscence and evisceration. So let's start with dehiscence. It's a surgical complication where the edges of a wound no longer meet. A lot of people say wound separation. A healthy healing wound had wounds that meet neatly and they're held together by sutures or staples. And when you start to see a wound kind of gape open a little bit, that would be dehiscence. The term evisceration is a rare but severe surgical complication where the entire incision opens up and abdominal organs are protruding or coming out of the incision. Evisceration is considered an emergency and must be treated as such. Now, signs and symptoms when you go down here, if it's dehiscence, you'll see some serosanguinous drainage from the wound. If it's evisceration, a lot of times people say they feel like something gave way, and you'll go over and you would see organs visible through the abdominal incision. This tends to occur about 5 to 12 days after the surgery. It's usually caused by sudden strain or some sort of stress on the suture line. This is a topic that kind of needs a picture. This is from the textbook. If you look here on the left, you see a wound that has dehisced. You can see what probably happened here. The nurse went to remove the sutures, and as she got to remove the sutures, you realize that a part of this wound was opening up with dehiscing. She would go ahead and leave these other sutures in and not remove them. This might be a wound that's going to need packed up a little bit in here. You'd have to notify your physician. This is not going to be it's not an urgent thing, but you would go ahead and call and say, I want to remove these sutures, and there is an open area, the wound separating. Sometimes they'll have you take out every other suture on one shift and then make sure the wound's okay, and then take out the rest of them on the next shift just to kind of make sure that nothing's going to dehisce. The one on the right is going to be a problem because we can't have these organs coming out of their home. Their home is in your abdominal cavity. And if you look at this picture, you can see this picture of the colon coming out, and that we have got to get this wound stitched up immediately. There is a standard treatment for evisceration. If a patient tells you something gave way and you go to assess that abdominal area and you see organs, you need to get the patient flat on their back. We don't want those organs coming out. That would be the first thing I would do. Which of the following is the first thing the nurse should do? Well, I need him flat on his back. I don't want to be catching any organs out. I'm not that nurse, okay? Once they get back and the organs are not going to be coming out for me, you're going to take sterile soaked gauze and keep those organs moist. Okay, and I mean sterile, not pretend sterile like I see people doing. Sterile gloves, sterile saline soap gauze, and keep those organs wet, and that incision is going to be stitched up. They're going to make room for that patient immediately as an emergency setting in the OR to stitch up that wound. It has to be done immediately. The infection risk is high. It's just a standard treatment. And I mean, this is one of those Sanka things in the whole world. You know, if anywhere you go, if someone finds an eviscerated wound, that is the treatment. You put the sterile soaked gauze on and you get that wound stitched up immediately. Just to reiterate the importance of the previous slide, wound evisceration is an emergency. You place the patient supine, you cover that wound with sterile saline soaked gauze or towels. They have to return to an operating room to repair, and you need to put in some assessment skills to monitor for shock. I'd like to discuss a little bit about post-operative drains. Drains are put in to prevent accumulation of fluids or air at an operative site. They usually protect the suture line. They may be removing bile or drainage from an abscess. The examples we're going to give are the Penrose drain, the Hemovac, the Jackson-Pratt, and the T-tube. Here's a picture of the 4 drains that you're likely to see. A is a Penrose drain, and they normally put a little safety pin in here. They don't want to lose this little tiny drain. This is normally used for, I will say, if you ever get pelleted with a BB gun and they go in there and take that little BB gun spot out and they need to drain, this is perfect for that. The one in B is called a T-tube, and it is used for the gallbladder removal. If you have a problem in there and they need to drain some bile, you will see this, and that's primarily where I have seen that particular drain. C is called a Hemovac. It is quite large. It doesn't really show in this picture how large it is. Hemo means blood, vac means vacuum. This works by compressing it. It kind of looks like an accordion. When you squeeze it shut and you close it, and as it fills up with blood, you have to go empty the blood out and then squeeze it back closed. The last one is called a Jackson-Pratt drain. I've also heard it called a grenade drain. I've heard it called a bulb drain, and it works in a similar way. You take it, and right now it looks like a grenade, but when you go to get it started, you squeeze it tight like a grenade, and you close the little cap. As it fills up with blood, it will pop open. Just a quick reminder about the signs and symptoms of a wound infection. Redness, swelling, pain, warmth, drainage, fever, increased leukocytes, a rapid pulse in respirations. The fever normally doesn't kick in until about 72 hours after surgery. And just keep in mind there is some redness when a wound heals. It sometimes gets a little bit almost swollen looking as the new tissue goes in there to heal and the cells go there to repair the area. Just a little bit more about wound infection. As I said, you'll start to see signs and symptoms of the wound infection 2 to 7 days post-op. They will have you run a test called they will have you do a CBC and run the CBC has the WBC in it. They may have you culture the wound. If there is an infection, they'll put appropriate antibiotics given for whatever time length is needed. I don't see a lot of wound irrigations, but it could possibly be ordered. We need to talk about shock and hemorrhage. Shock can come from the failure, the heart's not pumping effectively when you have a cardiac arrest. For surgery, it tends to be, shock tends to be, postoperatively would be a low blood volume. People have lost a lot of fluid. They're hemorrhaging or possibly hemorrhaging. People can get neurogenic shock. If their blood vessels, the nervous system kind of conks out on them, or you can get anaphylactic shock and you can get septic shock. These are all noted in your textbook. It's kind of important that you understand hypovolemic shock. It is the shock that I'm going to talk about here relating to postoperative care. Early signs of impending hypovolemic shock, if someone would be hemorrhaging, and the people are thirsty, restlessness, tachycardia, and tachypnea. So you want to look at these signs and symptoms. Well, most post-op patients are thirsty anyway. That's not normally something that I pick up on. Restlessness is also very common post-operatively. Watch people's O2 saturation. The thing that you would focus in on and would know that there was some type of hypovolemic issue would be the vital signs. When you are in shock and your blood volume is low, whether it be postoperatively or from hemorrhaging somewhere, the blood pressure is going to go down and the pulse is going to go up to kind of compensate for that lower volume. People often also get short of breath. Your respirations pick up to accommodate. And remember your urine output that we talked about earlier. We watch the urine output to make sure people are hydrated and they have enough fluid on board. And this is just common signs and symptoms. I know some of you saw the video I showed from Houston about someone that the nurses failed to recognize that somebody was in hemorrhaging somewhere. And the person had no urine output and an undetectable blood pressure on a blood pressure machine. Think about that. That person was in hypovolemic shock. You got to learn not to rely on machines so much and kind of rely on your common sense. If you don't see a urine output and you're looking at things that aren't right, we may need somebody to step in and give us a hand with some patient care if we think something is going to have there or hemorrhaging, possibly hemorrhaging, or something is going on internally. This is a list of interventions that are often done when someone is hemorrhaging or hypovolemic. They will give blood to the patient or what they call a volume expander. If there is bleeding, they're going to have to possibly go in and stop the bleeding. It might require another surgery. I don't know if you guys know, also there's a shock position. It's where you put the feet and the legs elevated and the head flat. That's to get all the volume in the body. We want to kind of get back towards the heart. They will have you give IV fluids or medications to raise the blood pressure. They will have you put on oxygen. They will increase the vital signs. If a person would be on just a regular med-surg floor, they may need transferred to a unit where they have more staff and more availability to do this type of monitoring or to be able to do these multiple interventions. There is a term or a condition that you need to commit to memory. It's called malignant hyperthermia. Malignant hyperthermia is a life-threatening elevation of body temperature that usually results from a metabolic response to concurrent use of certain muscle relaxants and inhalation anesthesia. Signs and symptoms include muscle rigidity, hyperthermia, tachycardia, respiratory and metabolic acidosis. Diagnosis is kind of done in the clinical site. I really don't know if they have any way to test you for susceptibility. When you go in to do your pre-op teaching, they ask you if you've ever had an issue with your temperature in surgery, and you have to tell them if you know or don't know. The highest priority that you have to do when a patient has this problem is rapid cooling, and they do supportive measures. They have identified some of the general anesthetic agents that tend to cause malignant hyperthermia. They're listed here: halothane, isoflurane, succinylcholine. There are some people that they just think are genetically predisposed to this condition. Post-operative, you have a lot of chance to do teaching, patient teaching and family teaching. And remember to keep your family and your relatives included in any discharge planning and teaching. And they say that a discharge planning occurs at the time of your admission. Sometimes you have to talk to family members. They may be doing the dressing changes. They may need to help watch and monitor for side effects of medication. They may need to look for complications. They may be the person providing general support to that patient during his recovery. Some of the questions and things you have to start thinking about: will this patient need assistance at home with bathing, meals, dressing changes? You may be responsible for arranging or contacting someone or arranging home health care. Person may need an aide to assist with bathing or a nurse to go out and do wound care. They may need oxygen or suction, and those things need to be ordered before discharge so they can have a smooth transition to their home. That's the end of this presentation. Thank you for listening.